Hi, class. I have another tough topic we need to discuss. That's intimate partner violence. Um, you guys should have the PowerPoint slides located in Canvas. Please feel free to take notes and ask questions. And of course, reach out to me if you're feeling um, uh, emotional regarding this topic. Um, why do we need to talk about intimate partner violence in pregnancy? It is heightened in pregnancy because this is a life-changing event for both partners involved. And so our pregnant women are at greater risk for domestic issues. And so I wanted to discuss what's the best way to ask a client if they're having abuse in their life. I feel most people will just kind of nonchalantly say, do you feel safe at home, right? Well, do you feel safe at home could mean a lot of things. It could mean, do you feel harmed at home? It could mean maybe they're at risk for robberies at home. Maybe they don't live in a safe environment, something like that. So I want to be more specific, especially in this population that has increased risk. And I have always used this after I learned it. Have you now or in the past ever been in a relationship in which you were hurt, threatened, or made to feel afraid? This is more specific. It's talking about now and have you ever, right? Been in a relationship, could be any relationship, doesn't have to be with your partner, right? In which you were hurt, threatened, or made to feel afraid. Doesn't have to be physical violence only, right? So this is the question that I ask all of my patients. Pregnancy is complicated by intimate partner violence. The goal of the abuser is to exert and maintain power and control over their partner. It includes physical, emotional, psychological, and sexual maltreatment. Intimate partner violence can include anyone of any culture in any relationship. It's not just male-female relationships. It can be any relationship at any time. Other common terms are domestic violence, spouse abuse, domestic abuse, or battering. Difficult to determine the extent due to unreported cases. A lot of women will not disclose this information no matter how many times you ask them. It may begin or escalate during pregnancy. Like I said, this is a life-changing event for everybody, causing high stress. With risk of antepartum hemorrhage, fetal growth restriction, fetal death, preterm labor, and low birth weight babies. The clinical manifestations, we use this cycle. We have the honeymoon phase. This is where the abuser will wine and dine. I love you. Do all of these things to make sure that she stays with them. The victim will agree to stay, will be happy and hopeful that everything is going to be a-okay. And then tension begins to build. The batterer will blame them, become moody or sullen. They'll yell and curse, maybe drink or abuse drugs. They'll start threatening, breaking things, and keep the victim away from family and friends. Then we have explosion, where there's verbal attacks, hits, chokes. They won't let the victim leave, use weapons, beat and rape the victim. And when this happens, the abuser will then begin that honeymoon phase again. I'm really sorry, I'll change, it's never going to happen again. And then our victim tends to believe them, and that's why they don't leave. If we catch them in our questioning anywhere in the honeymoon or tension building phases, it's likely they're not going to admit to intimate partner violence. Sometimes after an explosion, they will, but it's not often the case. It's very difficult to get them to verbalize what's happening to them. What do we do about it? We do routine screening of all women every time we see them. This needs to be done alone, and we make sure that we screen everybody every time they come in, okay? We need to be aware of our own common barriers. How do we feel about intimate partner violence? And then we do interventions directed towards safety assessment and planning. We need to be alert for danger signals coming from the patient. Maybe she's keeping her head down. Maybe we can see bruises or cuts or things on her body. And then we assist in developing a safety plan. We discuss her options. If she does admit to it, they can stay with the abuser, and oftentimes they choose to do that. We can remove the abuser through arrest or protective orders, or they can leave the relationship temporarily or permanently. We'll offer all resources. How do we care for these women? We need to be aware of myths, misunderstandings, and our own feelings on the subject. Again, always screen them alone and provide privacy. We're always non-judgmental, and we offer therapeutic communication. So regardless if they're going to stay with that person or not, we're always non-judgmental. Oftentimes they'll blame themselves for abuse. We avoid questions or statements which may imply the patient's responsible for the violence, because they're not, or that it's easy to walk away from the situation, because it's not. We document objectively when we're documenting, take photos of the injuries after she says it's okay. And of course, we're going to offer resources about all the local resources that they may have. This is the domestic violence hotline. I wanted to provide this not only so that you can provide it to your patients, but if you are needing help, feel free to reach out to me, to the counseling department at Gateway, and also to the National Domestic Violence Hotline. Number for it is 800-799-SAFE, or you can do it through texting as well. That concludes our lecture. I will see you all in class.